Good morning to those of you in person, and in the words of the late great broadcaster Sir David Frost, good afternoon, good evening, and good night to those of you attending virtually. My name is Ed Percy, and I'm the Vice President of Hospitals and Health Systems at Teladoc Health. There's a famous track from Crowded House called Always Take the Weather With You, and it would appear I've brought British weather to Barcelona, for which I can only apologize. On behalf of the IHF Organising Committee, I'd like to thank you all for attending this plenary session on humanizing technology for smart healthcare delivery, a central tenet of the IHF's special interest group on navigating the future of telehealth for hospitals, of which I'm proud to be a member. I'd also like to welcome our panel members for today's session and thank them for sharing their experiences and thoughts on digital transformation in healthcare today. Healthcare is the last of the great supply-driven industries, where access to data and services is generally mediated by the system itself, unlike all other industries who have leveraged technology to support service transformation, data and services available to the individual wherever and whenever they choose. Unlike those other industries, the use of technology within healthcare often has a very cold image, representing a shift away from the warm human interaction that patients are accustomed to within our healthcare systems. We are, after all, one of the most human of industries. However, technology-enabled healthcare has huge potential to better humanize healthcare systems and work towards a more person-centric experience, one of the IHI's quadruple aim objectives. And throughout the COVID-19 pandemic, there's been a rapid drive towards the use of technology, specifically focusing on technologies which keep patients out of the healthcare system, but allow their care to continue. Virtual consultation platforms, remote monitoring technologies, all of which we heard about in yesterday's sessions. And some of these technologies have the potential to make significant progress towards a more humanizing technology in healthcare. However, other technologies, or the way in which technologies are used, have the potential for the opposite effect. As our global healthcare systems return to normal, it's important that this is considered, ensuring co-production techniques are utilized to integrate the patient voice into actions around shaping healthcare services. And this is really the core of today's plenary session. Now, as befitting a World Healthcare Congress, we start our healthcare journey today in the beautiful Canadian city of Ottawa, where we will watch a short video from the Bruyère Research Institute. Roll VT, as they say, please.
Bruyère is a multi-site academic healthcare organization in Ottawa, Canada's capital city. We specialize in care of the elderly through rehabilitation, palliative care, brain health, and complex continuing care. We are comprised of hospitals, long-term care homes, and transitional care spaces that focus on maximizing quality of life and helping people stay and return home. We also have a strong community presence with outpatient clinics, primary care, and community programming. My name is Heidi Sveistrup, and I am the Vice President Research and Academic Affairs at Bruyère and CEO and Chief Scientific Officer at our Bruyère Research Institute. Our goals at the Research Institute are to support Bruyère's clinical and residential priorities and to improve care and our health system through research, innovation, technologies, and partnerships. At Bruyère, patients are not only a part of ongoing evaluations and quality improvement projects at the hospital, but many of our research and innovation initiatives with technology start with a patient or caregiver.
We had a spouse of a person living with dementia who told us that literally she doesn't sleep well at night because when he gets up in the middle of the night, she's not sure if he's coming back to bed or if he's going to walk out the front door, which of course could have tragic consequences in an Ottawa winter. And so they said, you know, is there technology that could monitor the activities of the person living with dementia in their home? So we developed the system, tested it, and actually used it in the community.
When the problem we're solving starts with the patient, we are building systems and services that directly account for their needs. With every iteration of the sensor system, our researchers aim to make the system seamless and ubiquitous, as we hear that feedback from patients and caregivers. And then, by working with industry, the products and services will be available for society. Whether it is technology that is digitizing our existing services or bringing a new way of assessing or treating patients to the forefront, we are changing the way people access healthcare. For example, the e-consult platform developed out of Briere and the Ottawa Hospital has meant significantly reduced wait times for patients to receive specialist consults. Patients who may have experienced challenges either because they don't live near a specialist or have limited mobility are now receiving care through their primary care providers who can connect with specialists digitally in a timely manner. Virtual rehabilitation has allowed more patients to take ownership of their rehabilitation remotely while still having a care team to keep them supported and engaged when they otherwise may have struggled to adhere to their treatment program. Implementing auditory screening has translated to improved communication between physicians and patients, as well as with the full interdisciplinary care team. This allows us to ensure patients are getting tailored communication across their care journey with us, resulting in better treatment outcomes.
For me, in the future, I might be able to prescribe an electronic system rather than prescribing a pill.
These partners are critical, not just in developing the technologies, but implementing them in a sustainable way within the regional ecosystem. Another key part of our success is to leverage technology to support the people who are delivering and receiving those services, not to replace them. We have to remember that the centerpiece is always the patient. What works for one person doesn't work for everyone, so implementing digital services needs to be done carefully. Continuous evaluation and research demonstrates where and how technologies work to reduce barriers and enhance equitable access.
And we will have the opportunity to hear from Heidi later in the panel session. Our first speaker is Dr. Anne Snowden, Professor of Strategy and Entrepreneurship at the Odette School of Business, University of Windsor, and the Chief Scientific Research Officer for HIMSS. Dr. Snowden is leading a national research program focused on the capacity of health supply chains to enable health system responses to the COVID-19 pandemic in 7 Canadian provinces. Dr. Snowden holds a PhD in nursing from the University of Michigan, an MSc from McGill University, and a BScN from the Western University. Please join me in welcoming Dr. Snowden to the podium to present to us on humanizing healthcare through digital transformation.
Thank you so much, Ed. It is an absolute honor and a pleasure to share some of this work with you today. In that video, and of course, many of the discussions we have been hearing about is the incredible potential of technology. But of course, in healthcare, we know better than any business sector, it's people and processes supported and enabled by technology that I would suggest really gets towards humanizing healthcare and looking towards a digital transformation strategy in order to do that. So let's begin with the people. When we reflect on this global pandemic in the last 2 years, exactly what does that mean and what has it meant for global citizens? It has had a profound impact on our quality of life. Without question, in Canada, we were locked down literally not able to leave our homes for the better part of 9 months. And only very gradually, very recently, are any of us starting to have direct person-to-person engagement. What did that mean for, of course, COVID? Patients with COVID, of course, shifted all of our care services and resources to helping those individuals manage such a devastating virus. But what about all of the other global citizens with other health conditions that didn't have COVID and were fortunate enough not to get it? They suddenly found themselves with very little, if any, access to health services, and they were thrust into a position of having to manage their health conditions and the challenges those presented. Communication was a profound challenge. What was really clear in this pandemic in the very early waves, but even today, is we relied on our news broadcasts, our prime ministers, our presidents, our members of public health agencies to direct and to help us manage to stay safe and stay healthy and well. But messaging changed rapidly. It was often inconsistent. I live on the border between Canada and the US. We would hear one series of messages from US experts, completely different series of messages from Canadian, only to leave the average global citizen to try to make sense of all of those very, very different messaging and communication strategies. What really was clear to me in the very early waves, but I think even continues today, is that health systems are not actually part of the digital societies, not meaningfully engaging people in the digital societies that we all live and work in pretty much every day of our lives. We go to school. I've been teaching for 2 years online completely with no person-to-person contact with students. We book all our airline travel, of course, online. We rarely see an agent until we actually board a flight. But when you really stop and think of it, health systems have not been front and center and completely engaging meaningfully the populations we serve. And perhaps if there's a silver lining that's an outcome of this devastating pandemic, perhaps now is that transformational moment for health systems to see the opportunity to meaningfully engage our citizens we all serve, populations we're mandated to serve. And that's really the premise of the remarks I'm sharing today. Consumer culture. Mindful that one size doesn't fit all. We tend to think about technology serving incredible opportunities to support people's health and wellness, but we're not all the same. Think of your parents and the way they approach healthcare, health services, working with health providers, and then compare them to our children. So when I think of my parents, I recall vividly when my mother needed a knee replacement. She selected the surgeon to do that surgery because she played bridge with his wife. And she was a lovely person, so therefore he must be the right surgeon for me. Our parents value stable relationships. They are exceptionally loyal to those relationships. They see health as a service. They're very willing to wait, and they absolutely defer to the expertise of the provider, which has served them very well. Now shift and think about our children. My children are in what you would call the millennial age group. They're not at all patient. They don't see the value in waiting for anything. They see themselves in many ways actually as invincible, perhaps. And that's been one of our challenges in Canada. Our younger population decided they were strong, they were healthy, they didn't need a vaccine, only to find in the third wave of the pandemic that was the majority of our ICU admissions. They're super connected. They're not loyal to relationships, excuse me. They're loyal to value, and it's value from their perspective. So when we think about digital transformation and driving transformation for the populations we serve, it needs to map onto the values and the needs and what's meaningful to segments of the populations we serve. What it will look like for our parents will most definitely look quite different from what it will need to look like for our children. So that really brings us to what do we mean by digital health? We talk about that a lot. Just before the pandemic, I was tasked with define digital health with the HIMSS organization. And when you look deeply across all of the literature, you find it is not a concept that it's exceptionally well researched and well defined. But when I looked across all of the concepts of digital health, it's no question it's about connecting and empowering people and populations to manage health and wellness, supported, of course, and enabled by provider teams that are accessible, working within interoperable and digitally enabled care environments. As we have now expected our populations and citizens to manage their health during this pandemic because health services in person were so limited, I would suggest that our populations will now be demanding this from us going forward. What we have seen is telehealth almost literally turned a light switch on overnight and became a dominant mode of delivering care. The millennials' early research outcomes are suggesting our millennial population, our children, thought it was the best thing ever, and in fact, they are unlikely to continue working with a provider that doesn't offer telehealth. Our seniors, our parents, not so terrific. They really rely on those stable relationships, and they like to be in person. All to say, the future of the post-pandemic health system is about ensuring we have the choices and we're managing and we're meaningfully engaging all of the population segments our health systems are served. So how do we go about that and where do we start? No question it starts with very strong governance and a workforce that's enabled and supported and incentivized to work within these digitally enabled environments. That absolutely protects data stewardship, privacy, and security that all of us are well aware of. It also then, to build onto that, requires interoperability, and that's the democratization of data. Seamlessly flowing data right to that point of care or to those individuals who need that data to start to inform decisions. And most global health systems, when we measure this digital capacity, do very well on those first two. Where we are seeing much, much, much less development is analytics, traceability. Analytics at the point of care to understand what are the key risks this particular patient is facing, and how, as a provider, do I help that person mitigate their risks? And more importantly, possibly, our outcomes. What outcomes are we achieving for whom in our populations we serve? And how do we achieve best outcomes and create the conditions for best outcomes for absolutely everyone we're serving rather than just a few? During pandemic, what was interesting and challenging, of course, in North America was African Americans and African Canadians had much poorer outcomes for COVID than their Caucasian colleagues, mapped to, of course, age groups. So how do we create that digital infrastructure to know which population segments are likely to achieve better or be at risk for not achieving as strong outcomes, and how do we create the conditions to shift our care delivery models to make sure every global citizen has an opportunity and access to best possible outcomes? When all those three dimensions come together, you start to build the digital capacity that meaningfully engages populations a health system served, and that's what drives population health and wellness. So what does it really look like at that patient level? Well, it's a person-enabled system. It's a system that gives people choices. Is telehealth, is point of care, our personalized digital tools the way that's going to work best for you? And what works best for one may be quite different than what works best for someone else. It's proactive. It looks at what patients' risks to their health and wellness are and proactively intervenes before those risks ever materialize. And it looks very carefully at population health. What are we achieving for whom? Under what conditions are we achieving best outcomes? How do we learn from that data-driven decision-making on models of care to ensure every population achieves those best outcomes? It also means transitioning from where we are today, engaging patients, ensuring they have access to their health records, their health data, often using portals or access to their EMR records, and moving towards adoption of digital tools that, of course, work best for them, personalized right to their particular health conditions, their health goals, and track their progress towards those health goals so that you achieve not just patient engagement, you achieve person empowerment, a dynamic, meaningful engagement between patients, their providers, that are working towards the goals I establish that are meaningful for me as a, excuse me, as a patient, and help me move towards those goals, of course informed by best evidence, best practice that clinical pathways have offered for many years. What it also means is a transformational shift between where we are today. We are very much still in that react and respond phase. We tend to wait for people to become ill, demonstrate symptoms, and then that system and those pathways intervene to help them restore health or manage their chronic conditions. Where we need to transform towards, and this is really where digital health is driving towards, is predicting and acting. Who in a population is at greatest risk for their health being compromised and why, intervening before those risks materialize, and focus very much on helping people stay healthy and well. When you think about the early waves of this pandemic, that's what so many of our public health initiatives were about. Stay healthy and well, mitigate the risk of being infected by this virus, predicting who's at greatest risk. Some countries did exceptionally well. Taiwan, just one of many examples, identified their most medically fragile citizens, wrapped home care and services around them before the first case showed up in that country, and they had among the lowest rates of COVID infections in the world, and particularly in those early waves. So moving from react and respond to predict, act, and support and enabled person-enabled care is really the future for a post-pandemic health system. What does that really mean in terms of the drivers of healthcare? I would suggest it's really considering redefining what we mean by value. Value up until now has been achieving the best possible financial outcomes with the best quality and safety available. But really what we are seeing in this pandemic, and I would suggest we will see in the post-pandemic phase, is considering what matters most to the populations we serve, and how do we personalize care delivery so that it's accessible, not just accessing services, but achieving the access to the best possible outcomes in order to achieve population health and wellness. It's very outcomes focused, but still care very personalized to the people and the populations we serve, and making sure and striving towards the best possible outcomes for absolutely every individual in a population, but building and working towards that learning health system that's driven by data and able to identify who are we achieving best outcomes for, under what conditions did we achieve best outcomes, and how do we learn from that and shift and inform and very agile and flexible models of care to ensure no matter what population segment we are providing care for, every individual has equitable access to the best possible care, but also the best possible outcomes. So with that, let me thank you ever so much for the opportunity to speak with you, and look forward to the panel questions.
Many thanks, Anne, and we look forward to hearing more from you later during the panel session, from engagement to empowerment and a redefinition of the concept of value in healthcare, very thought-provoking. Our healthcare journey now continues through the IHF global landscape, and we find ourselves in India, where we have a short 5-minute video from Apollo Hospitals.
India, a country with 1.3 billion people, 4,000 cities and towns, over 6 lakh villages, have most doctors living in the cities. This leaves a huge population living in smaller towns and villages without access to quality health care. With the country within the grip of a pandemic, doctors and paramedics, even while working round the clock, could not meet the needs of the huge populace affected by the outbreak. Healthcare had to be taken to each and every home. But how? The answer was to transform access, experience, and outcome through technology. Harnessing the powerful combination of technology and human ingenuity, we provided innovative care that was patient-centric. People needed access to care that was convenient, equitable, and affordable when, where, and how they demanded it. Whether it's one-to-one, virtually, or at home. To support this, our Apollo 24/7 app with Doctor on Call, Medicine on Call, testing at home, all at a tap of a button became an instant hit. The step towards humanizing technology helped the clinicians to organize and coordinate virtual consultations and remote monitoring of patients involving the family members and caregivers. We launched Coverage, the blueprint to fight COVID, an integrated multidisciplinary COVID care management program that was rolled out to drive awareness, assistance, and screening, along with robust treatment protocols, all by leveraging technology to provide safer person-centric experiences. Our AI-enabled COVID risk assessment tool helped over 1.4 million people across 51 countries. In anticipation of an increased need of medically supervised isolated care, Apollo launched Project Stay I, an innovative initiative to strengthen the bulwark against COVID-19 by creating isolation rooms in partnership with hotels to provide medical supervision for quarantine, freeing up the hospital beds for more critical patients. Every experience was personalized and differentiated with the launch of AI-driven health management program called Apollo Pro Health, built on the cornerstone to predict, prevent, and overcome the non-communicable diseases for helping individuals take charge of their health. Better outcomes were delivered using advanced diagnostics and precision care technologies like robotics and minimal invasive procedure, ensuring shorter hospital stays and superior outcomes. This further eased out resources so that we could care for more patients. Humanizing technology for the clinical staff was interesting in its own way. Our clinical dashboard helped clinicians work smarter and communicate better. Picture archiving and communication system helped our doctors to conduct a more accurate diagnosis with chronological view of their patient's medical history. Apollo e-Access, the modern and sophisticated critical care monitoring system for anytime, anywhere care, helped us reach out to the remotest places, providing quality critical care services round the clock. Similarly, teleradiology helped faster diagnostics, provided improved and affordable consultation for patients in rural areas, with expert physicians and radiologists sitting miles away. Humanizing technology means bringing the human connection back into the core of healthcare in the midst of the pandemic. We at Apollo Hospitals ensure that millions of lives are improved across the country so that the land of festivals, culture and heritage continue to remain a healthy place.
And we will hear later in the session from the IHF Governing Council member from India, Ms. Preetha Reddy. Our next speaker is my friend and colleague, Dr. Yulan Wong, who is a fellow at Teladoc Health. He's the executive sponsor for artificial intelligence initiatives and contributes to the company's corporate social responsibility efforts. Dr. Wong founded InTouch in 2003, which was acquired by Teladoc Health in 2020. And prior to this, Dr. Wong founded Computer Motion in 1990, the company which pioneered surgical robotics, including the first FDA-cleared surgical robot. Dr. Wong earned his PhD in electrical and computer engineering from the University of California, Santa Barbara in 1988, and was elected to the National Academy of Engineering in 2011. Please join me in welcoming Yulan to the podium to present on virtualizing healthcare delivery. Yulan, thank you.
Ed. Well, it's a real honor and pleasure to be here. And as Ed said, I'm representing Teladoc Health as a fellow And what's exciting about this meeting is it's in Barcelona, and I had the opportunity to visit our global international office at Teladoc, which is in Barcelona too. So just in terms of setting up the talk here, which is about humanizing technology for smart healthcare delivery, you know, Teladoc has been working in this area of digital technology for healthcare delivery for approaching about 20 years now. And so what I'm going to talk about is, you know, some of the thinking which has led to how we might be using digital technologies to provide more human care. I'm going to give a little bit on kind of the state of where things are today. I'm going to go a little bit into what are the types of things which might be doable tomorrow. And then the last thing I'd like to go into, if you'll notice here, I also put down an organization called World Telehealth Initiative. It's an initiative which has been enabled through Teladoc, where it's also using technology to help with the under-resourced half of the world too. So those are kind of the three items I would like to tick down. I think that this is the first meeting in person I've been to in 2 years, I think like many of you. And you can see what COVID has done. In our previous speaker said so eloquently about the adoption of digital technologies and virtual care, what happened with COVID. So if you want to think specifically about virtual interactions, this is from the Mayo Clinic in the US, where they were at a rate of several hundred, let's call it 400, 500 virtual interactions per day. And then within a matter of weeks, they jumped to about 8,000 a day. So then, as you can see, it backed down to maybe half of that, which is about 4,000 interactions a day. And I've in the meeting here, I've seen other graphs which look like this. There was a huge spike in the adoption of digital technologies, and then it settled back. But the settling point is significantly higher than where it was at the beginning of the pandemic. And now if I was to extend that graph out, it would be going up at about 20 to 30% now. What there's been, you know, surveys done, this is from last year, and it showed that only about 11% of health systems had been using digital health or telehealth prior to the pandemic, but today those numbers are in the 70, 90%. And then in the upper right-hand side, this survey showed that about 3/4 of people want to or are very interested in using virtual care delivery. So just as one example of adoption, perhaps at scale, and again, just using Teladoc as an example, which is one of the leading organizations that's in this area, we did last year maybe about 15 million virtual interactions with patients. And then we've also, the other thing that we've done is we take care of about 600,000 patients with chronic diseases and using digital technology to interact with diabetics, people with congestive heart failure, people with obesity or hypertension. And so I use that only as one example of, as you're trying to figure out how far this movement has gone. On one hand, it's just a smidgen of the overall healthcare system across the world. But on the other hand, it does show that you can start operating at scale with these kinds of technologies. The types of, in terms of the adoption of digital health, I think what we're all trying to do is to figure out how to adopt it within the context of the brick and mortar system that we have, that we've laid out for the last many hundreds of years. And one way to think about how this technology can be exerted smartly into our healthcare delivery system is to make it such that any patient or consumer, when they think about accessing healthcare, they think about doing it digitally first. It doesn't mean digitally only, but if I'm feeling sick, if I have a fever, if I need to see an expert, a cardiologist, if my blood pressure is high or out of control, if I just want some information for my own health or my family's health, instead of jumping in a car or on a train or on a bus and going to a healthcare facility and waiting for hours, perhaps the first step on any kind of healthcare engagement is to be done digitally. And that could be through a mobile phone, it could be done through a computer, it could be done through a telephone. But that's, I think, one very good place to start adopting these types of technologies in the overall healthcare continuum. So if you take an example of a fictitious patient, Bob here, and you think about how this technology-enabled digital experience might flow through an entire continuum. So let's say Bob has a very sore hip, okay? So what might he do? So he first would digitally interact with a primary care provider. So have a virtual consult. The primary care, he tells the primary care provider, I have a hip which is hurting a lot. The primary care provider then refers him into a brick and mortar hospital facility in consults with an orthopedic surgeon. The orthopedic surgeon analyzes Bob, checks him out, and determines, okay, Bob needs a hip replacement. But Bob is overweight, and so the orthopedic surgeon puts Bob on a digital application which helps Bob lose weight, because if he was to lose weight before the operation, the outcome is shown to be better. So Bob goes home and now is engaging through his digital application with feedback about exercise and about food and what have you, and uses the app to reduce the weight. The application is notifying his orthopedic surgeon and his primary care doc, such that when he hits the desired weight, it actually tells the orthopedic surgeon's office so that they now schedule a surgery. When it's done, when he's ready, Bob goes in, sees and has a surgery, perhaps is visited virtually by the primary care physician. The orthopedic surgeon does the operation. Then Bob is discharged from the hospital and then gets virtual visits from his primary care physician and perhaps the orthopedic surgeon as well. So I just use that as an example of how this digital transformation might insert itself into the flow of a continuity of care for a patient who has digital types of interactions in addition to brick and mortar. And so what I'm not saying is that everything should go digital. What I am saying is that if we can integrate and systemically mesh together digital capabilities with the very powerful brick and mortar systems we have, I think it will be a tremendously valuable improvement, and it will improve healthcare delivery. This is actually a picture, and I don't know if you can read it, but it shows the kind of continuum of different types of brick and mortar interaction points with a consumer or a patient. It shows, for example, a doctor's office, convenient care center, the ER, the hospital, the OR, what have you. And I think the idea here is to put in place the digital analogs such that for any given situation, the health system and the providers can determine if they're best interacting with their patients or consumers, if they're best doing it digitally or in person. And then you have the choice. And then you can have the patient flowing through the system as seamlessly as possible. Let me shift now and talk about kind of telehealth from an orthogonal or different point of view. So with something like, without these types of digital technologies, no matter how enabled the clinician is, they are only able to interact with patients who are in their immediate vicinity. But if you go ahead and enable the virtual interactions, now you greatly improve the reach of that provider such that they can interact with the right type of patients who are needed by them. One of the applications which has become, I think, pretty well adopted is telestroke. There's a stroke, it's the 5th leading cause of death, it's the 1st leading cause of long-term disability, and only a small percentage of patients who get a stroke are treated properly. And why is that? It's because of time. It's because time, it's difficult to get a stroke neurologist to the patient's bedside quickly. And so this is a perfect application for these types of virtual care technologies. This is a poster on the wall of the lobby of the Thomas Jefferson University in Philadelphia, where the center is their Plenary Center for Neuroscience, and all the labels around it are surrounding community hospitals. And what you can now do uses telemedicine in order to bring the expertise of that quaternary center at any given time to the outlying, I think there's 38 there, hospitals in that outer Philadelphia area. That map there covers about a 200 kilometer by 200 kilometer swath of land. So if you take this idea further and then you put it together with an area of technology that which I find very exciting, it was part of the earlier part of my career in robotic surgery. If you look at this picture, you have the surgeon sitting on the left looking into a console, and the patient is in the operating room table on the right with the robotic arms by that patient. And if you were to think about that robotic tool, it's really call it a standard surgical instrument, which is cut in half, and there's computerization between the two. And given that computerization, you can actually separate them. And so you can separate it by thousands of miles, and you can enable what is typically called telesurgery. So this is in telesurgery. Why would you have telesurgery? Well, it's because what we know is that practice makes perfect, and if you use a surgeon who has lots of practice and high volume of a particular type of case, and especially if it's a complex case, they have much better outcomes and therefore lower cost than surgeons who do much lower volumes. On the left here, it talks about a paper published by the NIH. It says that if you have a low volume surgeon, there's a 20 to 70% increased risk of death, 300% increased risk of complications, 33% risk for the patient for extended hospitalization, and can be twice the cost. This was for a certain set of complex surgeries. But the point is that if you can actually do surgery where you can extend the reach of the surgeon to a remote location, you can greatly improve the surgical capabilities. So I was going to show a video, but I'm not, because I see the timer and I'm going kind of long. But this is actually a surgery that took place in 2001, where 2 surgeons in New York City took out the gallbladder of a woman who was laying in Strasbourg, France. So that was a proof of concept of telesurgery. Was done 2 years ago. So why am I talking about telesurgery here? I'm trying to show that these digital health technologies aren't just to be relegated to very simple things like a quick consult for a cold or the flu, but can go all the way up the complexity hierarchy to helping to take care of patients who have a stroke or helping to deliver surgery. So I'm seeing that to make everybody hopefully agree that this kind of technology can go a long ways in terms of the changing and adoption of our health system. The last thing I want to cover here is it's about an organization, it's an NGO called World Telehealth Initiative that I helped form. Sharon Allen, who's a co-founder, is in the audience here. And the idea here is that another way this type of technology can be used to really humanize the delivery of healthcare is to use this technology in order to help us solve the problem, is how do we bring healthcare to the half of the world which doesn't have it. And so I think we're all familiar with this the challenge of healthcare in the underprivileged world. And with all that's going on in telehealth these days, we're building all of these remarkable capabilities of delivering care virtually, like the things I've already talked about, but it's being paid for by the developed world because it actually is how we are evolving the healthcare systems in call it the more developed countries. But what if we were to use that same infrastructure and use its excess capacity and use volunteer clinicians? As it turns out, it turns out most clinicians want to volunteer a piece of their time and use that capability to bring sustained care to the under-resourced areas of the world. And so what's interesting is that the digital technology infrastructure that is being developed is worldwide, and between the developed and the underdeveloped world, it's really covering both sides of that, and we're able to actually bring healthcare for the first time in a consistent, sustained way to areas like these. These are 22 active programs we have going on. You can kind of see where they're located in some of the different underdeveloped areas of the world. And the other thing which is worth noting here is the different types of use cases, the different types of specialties who are being brought to these areas to help these areas which are being serviced with these particular specialties because that's what they've said they need. And so if you look, for example, if you take the really long list in Bangladesh there, that's the one which is in the Rohingya refugee camp. And you can imagine they have no health care, and this is bringing in all these specialties into these different areas. So to summarize here and to end, with these digital technologies, we can actually, I believe, create much more humanizing, a much more humanistic healthcare delivery system. And this is Alan Kay, who developed the interface for the Apple computer. And I've always loved this phrase. It says the best way to predict the future is to invent it. And I think all of us here can spend significant time and have the intellectual energy and capacity here to reinvent it for a better world. Thank you.
Thank you, Yulan. Many thanks, Yulan, for sharing your thoughts with us today. It's a wonderful concept to take the digital infrastructure that's been developed over 20 years to support high-income world, the high-income communities, countries, for telestroke, for digital surgery, for remote surgery, etc. And to take that capacity, which is extreme and very large, and to use that plus the goodwill of the clinicians around the world to support the delivery of care into low to middle income countries. It's a genuinely fascinating thing. So thank you for sharing that with us today. Our next speaker is not able to join us in person, but has recorded her address for us for the session and will be joining us in the panel discussion shortly. And for the panel discussion, please submit questions via the conference app so that we can put those questions to the panel members shortly. Ms. Preetha Reddy is the Executive Vice Chairperson of the Apollo Hospitals Group, Asia's foremost integrated healthcare provider. Ms. Reddy holds a bachelor's degree in science and a master's degree in public administration, as well as an honorary doctorate of science from the Tamil Nadu Medical University, given in recognition of her outstanding work in the field of healthcare. Ms. Reddy also works with industry bodies and the government of India to advance policy decisions on healthcare and is a founding member of the Quality Council of India. Ms. Reddy will present to us on the COVID-19 impact on the Apollo Hospitals Group and the subsequent developments in their approach to humanizing healthcare. Please welcome Ms. Reddy to the stage virtually.
Namaste, Preeta Reddy here. I'm the Vice Chairperson of the Apollo Hospitals Group, and I'm delighted to be part of this conference and, of course, of this conversation also. It kind of surprises me sometimes that we're talking about humanizing technology for smart healthcare delivery. Let me put it this way, that smart healthcare delivery is definitely a need of the hour. In fact, it's a fundamental right to every human being on this planet. We have been devastated by what has happened over the past 24 months. We've been caught unawares. We've been trying to find different ways of handling this. And I think there has been amazing amount of healthcare models, people coming in to see what is it we can do, where we can be quick, we can be nimble, we can be fast, we can be cost effective, but more than anything else, we can be humane, because that's really what technology in the healthcare space is all about. At Apollo Hospital, there were multiple things which were done. Our ethos has always been touching lives. We have to reach out to our communities, and there were multiple ways where it was done, again, using technology. And a far reach, where India does not really live in the cities. It lives in rural India. More than 800 million of our population do not live in the urban areas. So how do we really take high tech and high value clinical care to their doorsteps? And I think that's really where it has worked so well for us. Our Prime Minister also has been very focused on the National Healthcare Digital Mission. And I'm so proud to say that the private sector and the public sector, which never really worked together, has now decided, has worked together as partners to take the best of technology, the best of human interventions to the farthest locations possible. So Apollo Project Kavach is something where 100,000 of Apollo employees literally came together to see how can we take the point of care to wherever people need it during the pandemic, come together seamlessly. And Kavach actually in Sanskrit means a shield. So the ethos, the whole philosophy behind it was, how do we shield people? And for those who have a problem, how do we protect them to a level that they're not frightened, they're able to overcome the disease? Because literally speaking, hospital beds are not available for everybody who needed it during the pandemic. So there was a lot of information and awareness created around it. There was around the clock helplines, which at some points were dealing with about 20,000 customers. There were 3,500 pharmacies which were working 24/7 to reach the right drugs at the right time to the people who need it. Not only COVID-related drugs, but all their routine requirements. A diabetic cannot wait till his insulin runs out and then something gets shut down during the pandemic. He needs it at the right time. Those with high blood pressure need their drugs. So I think the pharmacies really moved to see that drugs were available to people at their doorsteps. Quick turnaround time on testings, high-end testing. The labs ramped up across our network and our sister concern networks. So at any given point, we had about 4,000 labs really working again 24/7 to turn out results for wherever it was required. The fever clinic was a unique concept which caught on throughout the country very well, is that anybody who was running a fever during this time would report either physically or through a telephone into the fever clinic. They would be told what the right testing was, what the right protocols, care, quarantine required, intervention required, and the clinic really was there to hold their hand through the whole process. Again, there were not enough hospital beds or isolation centers. So the hotels came together with the hospitals, and we started what was innovative at that time, which said Stay I, that you could check into a hotel, you would have a room, all the comforts of being at home, but you would be monitored 24/7, again using remote technology, so that the command center would know exactly what was going on with that person who had checked into a hotel. So that was a very successful model. And 24/7 was monitoring patients, about 10,000 of them approximately, give and take a bit this way, a little more, a little less. But at the highest peak, it was a little more than that. And 24/7 monitoring, again using technology, which I think was a great example Apollo covered, showed that we could do it during the COVID times. Again, there was a risk scan app, which, after that, there were multiple apps which came, but you could take your COVID risk scan. And we had almost 300 million people globally who signed into just taking that risk scan. And that moved into the government one, which then the government propagated, and the back end again was done by the Apollo group and multiple other players. Treatment protocols were important because globally everyone knew and realized that the first few months were devastating, and then there were drugs available, there were protocols done, centers globally shared it with each other, and we could do whatever at the right time quickly. And that, I think, the outcomes got so much better because of just the right protocols. EICU again was a great project with us, that infrastructure within the hospital system was a lot, but not enough during the pandemic. So using technology, we could almost triple the number of ICUs in other locations and monitor them real time. Apollo 24/7 was, one of the biggest booms, as I said earlier. It made remote care mainstream. It made doctors available to consult in 15 minutes. Thanks to them, medicines were delivered at home in 2 hours, and lab tests at home again became huge. But to me, one of the best examples of humanizing technology was what was done, what we called as e-access, and I mentioned it earlier, was that families could really have access to the doctors at any time, any point, 24/7, using this technology at their homes. And they continue to do it. The crisis of COVID may be over, but the numbers are growing because of the sheer convenience of what somebody can do from whichever location they live in. The second opinion service, which now is becoming very popular, is that they could actually reach out after an opinion is given within their doctors to anybody, either if it's a chronic respiratory issue or multiple interventions, that the platform will really guide you into getting a second opinion service. And this has really reassured people, reassured patients to a large extent. One critical example was, patients needing ECMO. They were on ECMO in multiple locations. We had almost about 60 patients on ECMO at one time, but just networking with some of the best centers. So a doctor in the UK at Guy's and Thomas's was really walking our clinicians through that entire care continuum of what needed to be done, the right interventions during the ECMO program. So we saw that the survival rates actually jumped up by 20%, simply because we had one clinician, great expertise, fantastic decision-making supports available to guide a patient through what they needed to do. And these were some examples which really helped us. For us, again, prevention is always the key. In multiple ways, it can be a cardiac event, it can be a stroke, it can be a respiratory issue. But I think the predictive risk analysis and using the right diagnostics at the right time personalizing what you do so that each one who comes to your system is actually the most important. And the care is continued, not only during just the interaction, but the care continuum is wholesome and it's 360 degrees. And I think that prevents a lot of issues, a lot of hospitalization. And we've been able to do that. It's AI enabled, the predictive risk scores, and the path towards wellness seems so much better. The human interface. I spoke about the EICU. It was specially designed. It had smart proactive alerts. It had real-time equipment data available, high quality audiovisual support, and the assessment was the same and seamless in whichever location which was using it and adopting it. And so interventions again became quicker, smarter, easier for us to do. The CDSS, which I spoke about, the adoption of data, the communication, the resources which are deployed to really make these support systems so robust is a large number. And we think as we go along, it will only bring value, and it will definitely add on to the amount of data which is available for us to be able to do much more in the healthcare space. I think the impact of digital technology is huge. It is really going to do so well in the area of patient engagement, tremendous improvement we see. Physician access, and as I said earlier, if a physician was treating 4 people, he can find ways and means to really look after 400 people. So, 100x is the kind of numbers which a clinician can actually engage with people better, quicker, faster. Clinical outcomes undoubtedly will be better because number one is that the clinician is supported by so much of technology to be able to make a better diagnosis so that he doesn't really miss a pathway. But with the clinicians just touch and feel and intuitiveness, it gives them time to really use that much better. And I think that is really how there will be a tremendous improvement in what the healthcare delivery will give us. Again, improved lives. It will improve lives because with the right communication, with the right access, people will become conscious of the fact that they don't really need to either take unnecessary medication, they will learn to eat right, they will learn about early prevention, early detection, prevention. All this is going to become available to many more people and not just to the urban people living in cities or those who are upwardly mobile, because technology now is literally with the smartphones. I hope that you found this useful, and I really enjoyed putting it together for the whole group who's viewing this. And I thank IHF for the invitation, and I'm delighted to be part of this fabulous conference which has been put together so well and so diligently by the organizers. Thank you. And from India, Jai Hind. Thank you.
Well, many thanks to Ms. Reddy for sharing her perspectives on the last 18 months. 800 million people live in rural communities, and most doctors live in an urban environment, and that's the scale of the challenge, but also the scale of the opportunity for digital transformation to better serve the people in these communities. Our final presenter is also not able to join us today in person, but has recorded her presentation for the session. Dr. Heidi Sveistrup is the CEO and Chief Scientific Officer of the Bruyere Research Institute and Vice President of Research and Academic Affairs at Bruyere Continuing Care, a multi-site academic healthcare organization. As a full professor in the School of Rehabilitation Sciences at the University of Ottawa, her research focuses on rehabilitation and the use of technologies to support wellness, engagement, and long life. Under Heidi's leadership, Bruyere has doubled its research intensity, added a leading innovation program embedding Canadian technology into healthcare, and increased the impact of Bruyere's research and innovation across the healthcare sector. Please join me in welcoming virtually Heidi Sveistrup.
Hello, my name is Heidi Sveistrup, and I am the Vice President, Research and Academic Affairs at Briere, and the CEO and Chief Scientific Officer of the Briere Research Institute. While we are meeting today on a virtual platform, I want to start by paying respect to the Algonquin people, who are the traditional guardians of the land on which I work and live. I want to acknowledge their long-standing relationship with this territory, which remains unceded. I also want to thank Healthcare Can, led by President and CEO Paul-Émile Cloutier, who asked me to participate in this panel on his behalf. Healthcare Can is the national voice of hospitals, healthcare organizations, and health research institutes across Canada. As a nonpartisan association representing organizations in the health sector, Healthcare Can advocates for health research and innovation and for enhanced access to high-quality health services for Canadians. As I've already mentioned, I work at and for Briere. We are a multi-site healthcare organization that plays a critical role in our region's healthcare system by providing services across our 2 hospitals with programs specializing in stroke and geriatric rehabilitation, medically complex care, palliative care, and memory disorders. We have a 2-site family health team, 2 long-term care homes, including a village with supportive and independent living for older adults. Our newest transitional care hospital was added to our programming 1 year ago and has been instrumental in helping our region transition patients to appropriate levels and sites of care during the last year. As an academic healthcare provider, Briere is affiliated with the University of Ottawa and Carleton University. Our research institute focuses on finding our next generation of care for aging Canadians and vulnerable populations. So I'm going to start back a bit. In April 2004, one of our physicians, Dr. Frank Knofel, the headshot to the left, and his collaborators at the time launched the pilot TAFTA Smart Apartment at our Elizabeth Briere Hospital. TAFTA stands for Technology Assisted Friendly Environment for the Third Age, and the apartment was established as the program site for the integration and testing of selected smart e-health technologies. In 2005, he was joined by Dr. Rafiq Gubran, the headshot on the right. He was at that time the Dean of the Faculty of Engineering and Design at Carleton University, and he joined TAFTA as co-chair to bring expertise from the Carleton University engineering program to the research initiative. We've since expanded the work in this area and are now branded as one of AgeWell National Innovation Hubs, with our focus being on sensors and analytics for monitoring mobility and memory. The 3 pictures to the right show different views of the apartment. What you don't see are the many dozen sensors integrated into kitchen cabinets and appliances, ceiling and wall motion detectors, bed pressure mats, and smart light bulbs and communication devices. I've been lucky to join the group along with a number of other scientists working together to study, design, develop, and test different solutions that focus on how we can support and maintain the ability for people to remain in their own homes and communities for as long as they want, and to age as gracefully and independently as possible. The key to the work is to keep people at home through different mechanisms and tools, including the Internet of Medical Things. This is one of the early impacts of SAM3. Our scientists had the opportunity to speak with caregivers of people with dementia as part of a collaboration with our regional health integration network. When caregivers were asked what the research team could do for their loved ones, the caregivers actually said that their biggest problem was that despite wanting to be good caregivers and support their loved ones, they needed help to address their own lack of sleep. I'd like you to imagine if I was caring for my partner and was concerned about nighttime wandering. Any sounds or movements during the night would be a signal that my partner was awake and up. The dangers associated with walking out the door in Canada are quite significant. So I would be sleeping with one eye open and waking throughout the night. Over time, the fatigue builds up and I would become increasingly challenged to provide care during the day and my own health would deteriorate. So the nighttime wandering detection and diversion system was developed and tested through multiple iterations. The system uses sensors placed throughout the house that are triggered by certain events. For example, when the person living with dementia gets out of bed, the home turns on. Special lighting prompts the individual to go to the bathroom and then back to bed. If at 2 o'clock in the morning, the person wanders to the kitchen or other areas of the house, motion detectors sense activity and using cues communicated through personal assistants like Siri or Alexa, and importantly, in the voice of the loved one, prompts a return to bed. Sweetie, it's 2 in the morning. come back to bed and try to sleep until the alarm goes off, and we'll get something to eat together. The system has been shown to be effective in reducing caregiver stress and help with sleep because the caregiver is only awakened if the person attempts to leave the house. This has been critical. The caregiver isn't alerted when a sensor detects behavior, but rather the home provides active cueing and monitoring to assess the majority of behaviors until the point where the front door is opened. Caregivers have said that they could stay asleep knowing that their loved one is safe, even if they get out of bed, because they can't get out of the door without the caregiver being alerted. The nighttime wandering system uses off-the-shelf smart home technology, so it isn't difficult to implement in people's homes. Another example of our work, over the past year and a half, the pandemic has diminished the individual's ability to make in-person human connections with their providers. For many, seeing their regular physician became difficult as the focus in healthcare shifted to the long-term care, hospital, and emergency areas. Some patients, at least here in Canada, were discharged early from hospitals due to an overflow in COVID-19 inpatients, and of course, we saw complete slowdowns in elective and other procedures. We started working with an industry partner, Safety Labs, about a year before COVID hit us. The technology was going to allow us to go digital and remote for monitoring some of our patients at home. But it was important to continue to maintain meaningful connections and experiences for users by humanizing a set of technologies, websites, mobile apps, tech interface. And if we could, we wanted to take computers out of the computing. So our industry partner approached the issue using technologies that would be known to the user. And this allowed us to maintain a connection between the user and provider. A pre-configured health kit for vitals monitoring, blood pressure, oximeter, glucometer, and more, was connected through an anchor to the patient's TV. This allowed the interface to take advantage of a known technology, the TV and remote, to initiate and respond to interactions between the patient and provider. The use of the TV also allowed the provider to appear virtually in the home of the patient, keeping the very valuable human connection. The importance of the personal connection between our patients, residents, tenants, our older adults and their caregivers with the healthcare team is also fundamental in the example shown here. We have a virtual reality rehabilitation research program that is now integrated into care for inpatients and for patients living in the community. Participation of patients and clinicians has allowed us to recommend relevant and person-centered changes to the system that allows ongoing connection between patients and their providers. With COVID, we implemented a fast auditory screening tool called Shoebox. The majority of older adults have hearing problems. And in our study of Shoebox with our geriatric patients, we found that many who had moderate to severe hearing impairment were not aware of their deficit. COVID exacerbated this situation with patient visits since now our staff and patients had to wear masks. This muffled speech and made it impossible to use any cues from lip reading or facial expressions. Establishing a hearing screening program across multiple sites at our hospitals has increased the use of pocket talkers and auditory referrals. Patient satisfaction with care has also been impacted. At the bottom, you can see how we deliver electronic consults through our primary care teams. Imagine the following. I go to my primary care provider with a rash, and she isn't quite sure what it might be, so she refers me to a dermatologist. There's a delay in diagnosis and treatment because it takes a while to get a specialist appointment. The specialist may need me to get some blood work and then see me again. With e-consult, much of the work can be done with a single visit to my primary care physician who can provide images, blood work, clinical impressions, and more to the specialist through a secure portal. The e-consult system co-developed at Briere is now a service that has been rolled out across many provinces in Canada. Even before the pandemic, the adoption of IOMT was already growing rapidly, and there are more than 500,000 medical devices on the market, helping to diagnose, monitor, and treat patients. And more of these can and are becoming connected. More innovations are being developed, and the 500,000 number does not include the innovations supporting care through wellness technologies. Because we are physically located in sites that deliver healthcare across the spectrum, our physicians and healthcare staff are integrated into our teams. Our relationships with universities and colleges extend our research capacity through collaboration with academic researchers and the inclusion of trainees. And finally, we have an increasing cluster of industry partners who bring additional expertise to our work and who provide a mechanism for our work to inform development and commercialization pathways. But most important and fundamental, our patients, families, residents, tenants, our community living older adults and their caregivers are key players. They identify the challenge or the problem, and as one of our scientists puts it, they tell us in the bluntest way if we've got a solution that works or when it doesn't work. I want to thank you for your time and hope that you enjoy the rest of the panel.
Well, many thanks to Heidi for that presentation. Seamless and ubiquitous access to technology is key to the transformation. I now have the pleasure of welcoming Ms. Reddy and Dr. Sveistrup, who are joining us virtually from India and Canada. And on behalf of the IHF Organizing Committee, I'd like to thank Heidi, Preetha, Yulan, and Anne for joining us here this morning, stroke this afternoon. The pandemic has been a forcing function for shifting the patient experience into a more digital world. And we now have the opportunity for a panel discussion with our esteemed presenters. We also have some questions rolling in through the conference app, and please keep these coming in. And I think I'm going to go first to Heidi in Canada with a question from Anonymous. If digital engagement with patients is the way forward, and I think we can all agree that digital is a very important aspect, how can we support the education and training of clinicians on this issue? And what lessons have you learned, Heidi, within Bruyere around the training and education of clinicians in this new digital world?
So thank you for having me at the meeting virtually. I wish I was in Barcelona. The weather is much nicer despite being British weather from what you said today. That is a challenge. And I think it's not just, it is the patients, it's their families, and it is an issue for our clinicians. So digital literacy, so digital and tech literacy is one of the bigger issues that we have when we think about, addressing digital and digital health and the healthcare system. We often think about the stuff, the equipment, the computers, the phones, and what we need in terms of the technology and the broadband, et cetera, et cetera. But we don't often think about, as Anonymous puts it, the education behind it and the ability to have some sort of learnings. On the patient side and family side, we have worked very heavily with a group called Connected Canadians. It's a not-for-profit that comes in and actually does training with our patients so that they become increasingly digitally literate as they're inpatients, and then when they go home, they're able to use their technology. It's been really interesting to me to see the issues that we continue to have with our staff. When I first came to Ottawa, I was the first person to use a computer for a presentation in my program in rehabilitation sciences. So that dates me a little bit, but that puts it at about 25 years ago. But we still have frontline healthcare providers who are nervous about computers, who don't understand technology and have a little bit of an issue with that. So I think what we have to do is actually think outside of healthcare and work actively with education systems, schools, continuing education to provide knowledge about the art of the possible in digital health and also the use of digital technologies. We've seen some really great programming at Bruyere where we have engineering students through their program, the 4-year program. They come in and they work on clinical units where they're actually embedding and trying to understand the issues that we have. And then they can actually work with our clinical people to help identify the art of the possible and then how to use some of those opportunities. And then the last point, which we're looking at right now, a lot of the outcome measures, especially in rehabilitation sciences where I am, we know that the outcome measures are valid and usable when we're seeing the patient in front of us. But you can just imagine sending a patient home who you want to do an assessment, a MOCA, Montreal Cognitive Assessment, or a GATE assessment, and then trying to do that over the internet and have valid, reliable outcome assessments data. And so what we're seeing is that we have to really help the clinicians who are then helping our patients to set up cameras appropriately so that they actually can see what they need to see and have the data delivered to the physicians or our rehab nurses and staff. I'm not sure if that answers your question, but I think a big part for me would be to say healthcare is not a box. It really has to reach out to the education system, including the schools and continuing education, so that we can continue to develop those skills in the next generation.
Great observations. Thank you, Heidi. It's certainly clear that digital literacy is key in this, and it's very interesting to hear that, that there's an engineering component in the engagement within the medical community. That's really interesting. We've got some great questions rolling through the chat here. So we're going to throw away the questions I prepared in advance, and we're going to go to some of these. Preetha, specifically to Apollo and the experiences in India, there's a question, how did you manage other health conditions not related to COVID? And how did you manage the shortfall in clinical staff, especially in specialty services like critical care and internal medicine?
So I think it was a huge challenge. There's no going away from it. You know, it's a large country, the remote locations. But having said that, the EICUs, which quickly were, organized using technology, using a large number of personnel who literally work 24/7, we managed to, do the COVID care in hospitals which are, very distant from the city. So there was a hub and spoke model in place. Today, it's the emergency rooms, it's the cardiac, it's the stroke. But at any given point now, we are managing approximately 2,000 patients needing critical interventions in multiple locations. And I think this is going to become the norm, and it will happen. So here, our technology, of course, played a great role. And thank God for the fact that we do have 4G, 5G, and the kind of bandwidth which is available in the country. So this did happen, and I see it continuing to happen in multiple formats. In terms of not having enough personnel, I think that is an issue, and that is a problem because our staff to patient ratio in a country like ours is sometimes it's even scary. We have one doctor for every 10,000 patients, which is really not the norm at all. And a lot of them also have to keep upskilling themselves. So I think now there is a concentrated focus. And we at Apollo started a division for just e-education training, skilling called MedVarsity. And this is able to train people as quick as they can to use it. Our ventilator training program, in fact, was used globally. It was just a free instruction manual for people just wanting to use ventilators, and it reached a few thousands of people, and it's continuing to gain momentum. So I think interventions like this are required, and the training and skilling is a huge aspect to delivery of healthcare, even and with technology backing it. Now they're not on opposite sides. Now it's together, and it's a congruent exercise. We should be able to overcome this, but as on date, the intent is there, which may not have been there a few years ago. Is that the journey ahead is not going to be easy, but I think we will achieve a lot in the next 24 months.
Thank you, Preetha, and inspiring the story around the ECMO engagement and collaboration with the clinicians in London, guiding and training your own teams. It's an amazing story.
I'm just totally grateful to them for doing that for us.
Yeah. And that's the power of technology, and then the willingness of clinicians around the world to help out. Which, Yulan, leads us on to a question relating to the World Telehealth Initiative that's come through. Could you please explain to us how the sites are chosen for an engagement within the World Telehealth Initiative?
The sites are really chosen through a process where they they're introduced to WTI, and then the WTI kind of goes through a vetting process. And the vetting process, it turns out, for example, there are sites which are even so low resource that WTI can't help. For example, if they have no internet, and if they can't support some technology on site. But fortunately, there's actually, internet is quite pervasive around the world now, and so that's kind of the less common situation. Then it's basically about what are their needs, and then WTI has to go and find the corresponding help. And at first, WTI is only 4 years old, and it was unknown how difficult or easy it would be to get volunteer physicians. And I'll tell you, it's been such a wonderful thing to see that the vast majority of physicians want to help for free. And actually, there's a few hundred physicians now who help WTI, and they're thankful for, as opposed to saying, I'm just kind of doing my due to give back a little. They're actually thankful for the experience, because it turns out they learn too, and they're meeting new friends, they're learning new cultures, and actually we've had instances where some of these physicians will then travel to the site because they've made relationships. So it's not a very precise answer to your question, because it's done a little more organically these days than very systematic. But the volume of sites and the volume of physicians who want to help, it is actually, there's no shortage of that.
And is there a technology solution that you are looking to develop to support that process of matching need with expertise?
That's an insightful question, Ed, and we are, because to run at scale, at 22 areas with hundreds of physicians, we can do it one way. With thousands of clinics and perhaps tens or hundreds of thousands of clinicians, it's going to need technology to do that, and we're working on that type of technology.
Very interesting, very interesting. That sharing of expertise globally. This is the most global of industries.
Yes.
And with the diaspora of clinicians around the world, first and second generation immigrants into different countries around the world, the opportunity to provide capability and service back into those countries is really compelling. And I can understand why there's a huge demand, untapped demand at the moment in the clinical
And it is we live in one world, and it's a global world. And, COVID has taught us that we're all interconnected. So quite honestly, it's even, you could even say a little bit of selfishness. You want to help take care of the underdeveloped world because you can be on top of future pandemics and other challenges which might impact the entire world.
Yeah. I know at the start of the pandemic, there were a lot of communications going on between senior leaders in different countries around how the virus and its impact on different types of patients was progressing. And as the knowledge was building, it was literally being shared between handfuls of doctors around the world.
That's
and
right.
I think what we have now is the ability to build almost a situational awareness network using technology to support a rapid response for the next one, which hopefully will be some way off. We have a question here, Anne, that I think you would find very interesting. Have you found that there are areas of medicine in which telehealth is more beneficial than others? And has the pandemic changed the perspective?
Yeah, great question. Telehealth, in some of the research we're seeing, is exceptionally great fit for certain segments of the population. So it's less about what types of medicine are best suited to telehealth, and much more about what population segments does it really achieve value for. I think where we are in this pandemic, and hopefully, as you suggest, coming out of this pandemic, we very rapidly switched, amazingly actually, to telehealth. healthcare's long been identified as glacial in change. Well, we've proven we can turn those light switches on very quickly. I think where we now find ourselves is how do you measure quality and safety and value in a telehealth or a digitally enabled environment? I'm not sure we're there yet. And to go back to an earlier question, what are the key conditions of an ideal workforce, work environment that's digitally enabled for the workforce? How do we rethink our workflows to make our work environments much more automated, much more seamless, so that we remove some of the burden that we're seeing and the phenomenal burden our workforce has been facing. So I think those are key challenges in the post-pandemic future we really need to invest time in.
Great observations, Anne. We're going to stick with you because we have a question from someone who's not anonymous. It's from Els van der Wilden, so thank you very much, Els.
Thank you.
And Els has asked, Anne, what is needed to speed up the supply chain work to benefit clinical work?
Supply chain infrastructure, maybe this is another silver lining. Yes, that's a great question. Supply chain infrastructure is absolutely not developed nearly to the degree it needs to be. Prior to this pandemic, when I used to speak on research in the supply chain infrastructure for healthcare, people looked at me and wondered why this was important. I think we now realize it's so critical, and it is demonstrated when your supply chain is not functioning well, the health of your workforce and the health of your populations are deeply, deeply impacted. Where we've absolutely got to get to very quickly is data standards. There's 56 names in one health system I'm aware of for one type of glove. So 56 names for one type of glove, globally standardizing what product with what attributes is needed for what types of care delivery will be critical. The other thing we're seeing in supply chain is it has been very focused on lowest cost. So 90% of North American health systems, of course, procured from lowest cost environments like China for their products. That did not serve us well when China was, of course, the first global area to be in quarantine. So now we're seeing a much more globally balanced strategy for supply chain and building resilience and agility into healthcare supply chains so that health workforce have the products and the capacity to deliver care whenever it needs to and in what types of volumes.
Fascinating, and I'm intrigued to learn that healthcare interoperability and semantics is a challenge also in the supply chain in terms of the semantic understanding of data. We have a very interesting question that I'm going to pitch to Preetha. It's from Tom Balthazar. Is there not a danger to forget how important the emotional and psychological aspect of a real talk with a caregiver is? People begin talking about a simple physical problem, but very often really hope to talk about other emotional problems.
So I think it's a genuine problem, and we saw a lot of it because, the clinician is completely one-on-one in terms of engagement with the patient. I think that's where the education of the clinician is very important, that, they take the whole thing to the issues pertaining to someone's health. But having said that, the mental health of a person, you have to be cognizant about. And that's where I think the high touch and the high tech comes into play. That however high tech we are, we can't really lose that interface with the patient, the high touch aspect of it. So I think it's a lot depends on the clinician and how he can judge and where he takes the conversation without losing track of the clinical aspects of what has happened. But I have to flag the fact that, during COVID, there was a lot more about emotional discussions, people just wanting someone to talk to. And as we structure and as we design for the future, the mental health aspect is a huge problem, not only in a country like ours, but globally. So I think the questions asked, the interaction, the interface will take into consideration the fact that, this plays a lot into the way people deal with their own personal health. So it's going to be there. So that, to me, that's the high touch aspect of being high tech.
Excellent. I think we're going to see a surge in mental health service requests as a result of the pandemic as we begin to emerge both on the patient side and I think on the provider side as well. Well, we started the session late due to me bringing in the British weather, and again, for which I apologize. So we don't have any more time for any more questions. Please, just some closing comments. Please share your takeaways from today's session and post them on the Congress app and social media and use the hashtag IHF Barcelona. The recording of this session will be available on the event platform in just a few hours, and you can access this and all the other sessions for a month. We now have parallel sessions, so please check the Congress app for the session information and the location of the rooms. And then join us today at 2 p.m. for the closing plenary session, where the Minister of Health of Catalonia and the Director General of the Dubai Health Authority will share key features of their hospital and healthcare delivery systems and discuss the importance of international collaboration. 2 o'clock today, closing plenary session. I'd like to thank our guests here today for sharing their thoughts and experiences with us. And I'd like to thank you, the audience, both real and virtual, for spending your time with us here this morning, this afternoon, this evening, or even this night, depending wherever you are. Thank you, everybody. Thank you.